Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Therapeutics. We've been off for a few weeks. Some could call it a summer break, if you will. But also, if you don't know, I'm your host, Rain Bennett, by the way. But if you don't know, one of the main reasons we took some time off is because I just had a little baby. My son, July 4th, came into the world. And so we took a few weeks off to regroup before we brought the show back, which we're excited to be back. I missed you all. I hope you missed me as well. Again, my name is Rain Bennett, and I'm a filmmaker, and I've been working with CCF for a decade now to help them use video basically to carry out their mission, which is to spread awareness and to educate people about neuroendocrine tumors. That's what we're here to do. And so we've been doing the show now for over a year. I think we're right at almost 50 episodes, which is incredible. It's been a great part of my life and my career, and I know that it's been impactful for you all as well. And I just can't thank you enough for being a part of the show. So if you haven't attended the show before, what we like to do in the beginning is just say hello, tell people where you are in the world, where you're signing on from, get to know the community. One of the main benefits of the show, besides the information you're going to get from our guest today, is the community, is the conversation that's going on in the comment section. And you all know that the neuroendocrine tumor community is a strong one. Everybody is connected and engaged, and I love it because it's evident. It's evident in the show. We see it every week. So let everybody know where you are signing on from in the world. And if you are a regular, a friend of the foundation, you're probably already doing it. So before we get started, we always want to thank Therapeutics for their support of Luncheon with the Experts series. Without them, we wouldn't be able to do this. And we just want to let you know that the opinions expressed by the guest presenters, as well as the questions asked by the audience, haven't been created or suggested by the sponsors of the Facebook Live program. And CCF does not endorse or promote any of the views, opinions, or information provided in this presentation. Audience members, that's you all at home, should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that last line is really the takeaway I want you to latch on to, which is that, listen, we're going to give you some good advice, some good general direction, but by no means do we know your specific case. So take that advice, take that general information and direction back to your home team who does, and make the best plan and path for you moving forward. So today, our guest is Dr. Michael Choti. Dr. Choti, how are you?
Good morning. Good. At noon, it's 9 o'clock here.
It's morning where you are. Tell us where you are in the world and tell us what you do. And the way I like to phrase it is your role as you see it in this neuroendocrine tumor community that we've already talked about.
Thank you, Rain, and great to be a guest today. I'm a surgical oncologist here in Phoenix, Arizona, chief of surgery at Banner MD Anderson. Long interest in neuroendocrine cancer, neuroendocrine tumors. My background is a GI cancer surgeon. I've been in the business more than 30 years, something like that range, so a long time. My career really started at Johns Hopkins for many years, where we really built a strong neuroendocrine program, and served on the NCCN panel for neuroendocrine for many years. And my life then took me to Dallas, Texas, where I was chief of surgery, and now over the last 3 years at Banner MD Anderson, where we really, I must say, built a terrific surgical program, but also our neuroendocrine program here has been also outstanding. So, and a lot of members of CCF are here in our community here. So really, it's been a pleasure to work with the organization. A pleasure to be here today.
Awesome. Well, we're happy to have you. And, we were talking briefly before we started the show today about maybe former patients being here. And I just want to give you a little shout out. Lisa Stevens says, former patient from Maryland. Hello, Dr. Choti. Good to see you. And we also mentioned before we started how far this program reaches, even when we're live and not just watching the replay. So Jules says, good morning from Australia. So we have Australia in the house, San Jose, a lot of North Carolina, which I'm happy to see. and all over, people telling me congratulations. Thank you, everybody. That's my son Bishop. I'm very happy to have him. But let me tell you, we're in week 3 and I am in the thick of it. So I'm happy. I'm happy to be with you today. But night times have been challenging. Life is beautiful, right? So before we get going, let's talk a little bit more about the show before we start taking your questions. You can go ahead and start sending your questions in. And we're going to try to get to all of them, but if you attend the show regularly, you know that we get a ton of questions. So inevitably, we probably won't get to them all. And if we don't, I want you to reach out to Carcinoid Cancer Foundation. You can either message them privately here on the Facebook page. You can go to their website, carcinoid.org, and send them your question or your follow-up question. If you did get a question answered today, just know that they'll do everything in their power to get you the information. They probably have it there on their website or an easy link to send you. And if not, they will get you the person or people who can get you the information. This show will be, it'll live here. It'll be evergreen on the videos tab. So as soon as we're done, it's going to be posted to the Facebook page of CCF, and you can access it, or anyone else can access it at any time if you want to rewatch it. And starting Monday, we republish it to YouTube for those who don't have Facebook. Now, I like to ask a couple of favors of you all, if you don't remember, before we get started, and you do a great job of this, helps me do my job, which is to serve you, of course. One, the benefit of this show is this interactive virtual one-on-one session. Of course, if you watch the show after we're done, you can get some value from it. But the real value is being able to get a question across to somebody who has been, in our case today, working in this field for 30 years, right? So if you know someone that should be here, someone that could benefit from this, you can tag them in the comments. You can share this video to their profile, text them, call them, email them. Let them know that this is going on. Let them know that the show is back, and get them here, because they're really that's where they're going to get the most benefit from the show, is asking their questions live. And then the second thing I like to ask, in the comment section, you can see other people's questions. If you see a question that you also have, or you're interested in the answer to, Facebook gives you a few options, but you can like it, you can love it, any of the emojis that they give you access to. But effectively, what they all do, they do the same thing, which is it upvotes it. It lets me know there's a demand. So if I see 100 questions and question number 13 has 7 people that have liked it, I'm going to know, hey, this is a very important question that we need to get across. Just helps me, filter through those a little bit, so that we can get those questions in demand to, get them answered for you. And finally, before we get started today, have you downloaded CCF's free Net Cancer Health Storylines app? This app is amazing. It makes it very easy to record your symptoms, your medications, nutritional concerns, moods, all of that. So if you haven't, check it out. We will put a link to that in the comments. And to that point, if there's anything Dr. Choti mentions today, a resource, a medication, an article, anything like that, we're going to add that to the comment section as well. So you don't have to be, what did he say, writing down notes and opening a browser window and trying to Google for it. We'll do all that work for you. All right, let's get into it. Start sending in your questions. Dr. Choti, 30 years, my friend. That is that's a career in this unique disease that we work in. I know that a lot has happened over that time. What have you seen, like, from the beginning of that career? What are the leaps and bounds that you've seen that we've been able to take in our ability to diagnose this disease, to treat this disease? What are those moments that really launched things forward in that span of time? I know that's a big, broad question.
Well, we're continuing to understand this disease. It's even the name neuroendocrine, which there's no real site of where it originates. The neuroendocrine cells, if you will, can be throughout the body, obviously in pancreatic and midgut are the more common, but really, so it's always been thought of as a kind of an orphan, but yet we're learning more and more about it. It's becoming more defined, and it's not just not just a form of pancreatic cancer or intestinal cancer or lung cancer for that matter. So it is in a unique spectrum, and we've really learning that it's a family of different diseases. And now, not only based on the as I mentioned, the distribution, the site of origin, but the spectrum from well differentiated to small cell or to very more aggressive variants, and other factors that predict the biology of the diseases. We're learning Ki-67 and differentiation and so forth. but I must say there's still a long way to go. We're still learning a lot about it and learning about the biology of it, and so in that respect, it's complicated and but yet interesting. The other piece is that it's an area where many of the standard medical oncologists, surgical oncologists, radiation oncologists don't have a good understanding about.
Yep.
And so, in part, that's why it's resulted in a strong interest among patients. These are diseases where there often can be very indolent. Patients live for a long time. It's confusing. Many oncologists in the community don't understand it, and because of that, it's necessitated almost a really an empowered population of survivors that really want to understand more about the disease. So that's one aspect of it. And the other is that there is a spectrum because of the lack of understanding of it. There's a whole spectrum of recommendations of understanding just what to do, from
Yeah.
very aggressive to less so to so forth. And that's evolving somewhat, but still it still remains a particular challenge for
Yeah.
this class of cancers.
Absolutely. Well said. I mean, we're learning every day still. And I think it takes constant pressure to continue to learn those things about this disease. I think shows like this, I mean, I'm not trying to say that to toot our own horn, but continuing to have conversations, whether it's patients or medical providers, I think is the way that we can continue with that. Starting to already get a lot of questions, Dr. Choti, so I want to go ahead and start taking some of those. I think you and I could probably talk for a while, and we will some more. But I've got a question that came in from Karen. It's pretty topical these days. And Karen says, "I still have not received my COVID-19 vaccine. Is it still worth getting now? I'm kind of scared still." And Karen is a NET patient, I believe.
Yeah, so we jump right into controversy here, but I do think short answer is that from a cancer survivor standpoint, as far as I know, there's no contraindication whatsoever to, because she is a NET survivor, that should be a contraindication to receiving the COVID vaccine. So I mean, I personally strongly encourage it for everyone, and I think that it's worthwhile doing. Certainly there's unknown and pros and cons, and everyone has their own opinions about it, but from an oncologist, from a physician recommendation, there's that I know of, no contraindication unless there's some unusual therapy or that this individual is ongoing. But for as a standard NET cancer survivor, there's no contraindication to the COVID vaccine
Yeah.
that I know of.
Yeah, thanks. And thanks, Karen. I hope that helps. I know that you attend the show weekly, and this kind of question has come up a lot, obviously, in the past year or so, and with the vaccine in the past few months. So hope that helps, Karen. Good luck moving forward. Next question comes from Kevin and a few other people, it seems. Kevin says, understanding carcinoid is complex, but do you feel that the advances in treatment have changed the survivability statistics?
I think they have. As I mentioned, it's difficult to know the precise answer to that question because it's really a compilation of different diseases with different biology and whatnot. But I do think we've definitely moved the ball. We have a greater understanding of it. We have additional therapies, already. Even the natural history in some situations of low grade, relatively indolent disease, even the natural history can be fairly variable and fairly prolonged. But saying that yes, we've made advances with therapies, and with that, I think we have moved the ball as far as survivorship and quality of life for that matter.
Good point. Good point. Thanks, Kevin. Diane says, would there be any reason to use lanreotide or sandostatin with lung primary and mets to the liver but non-functional?
Yeah, I don't have as much experience specifically with lung, but in general, certainly with measurable metastatic disease, even in non-functional, more well-differentiated neuroendocrine, I think that's included in the lung and for lung primaries as well. That long-acting triotide analogs, lanreotide, sandostatin, LAR, for example, whatnot, would be indicated. I don't know specifically. It may be that maybe other experts that know specifically about lung, but my understanding, certainly on the GI side, that yes, metastatic disease, non-functional, liver metastasis or elsewhere, there's an indication for that there.
Gotcha. Thank you. And Diane, sometimes one of our friends of the foundation, Dr. Robert Ramirez, who does work with lung nets, kind of hanging out in the rafters like the Phantom of the Opera, and he may chime in. Sometimes that happens. Can't guarantee it, but sometimes he will. Let's move on. Tina says, I had a liver and colon resection 4 years ago. My oncologist said I would be fine and said I would be fine and live a long life with multiple denials by insurance. Sorry about that. For a NET PET scan. I finally had another one and have 4 places in my liver and 2 more in the peritoneal area. What am I supposed to do now? I'm not doing any treatment. So that's a little specific, but any guidance or thoughts on that?
Yeah, I think in the case of, it sounds like she had metastatic disease. I assume the primary, it's not clear, but I guess from the bowel. And then I assume she had no evidence of disease. We say NED or no evidence of disease in that situation, which is good, unless there was so-called some kind of cytoreductive surgery. That is, there was remaining metastasis. It's hard to say at the time based on that story. Saying typically if there's no measurable remaining cancer, even with stage 4, we typically don't recommend any therapy, but just continue to watch. And again, if it's functional or not, it's another issue. But in this case, let's say it's not functional. In this case, it sounds like she was not on therapy, and now there's evidence of recurrence. First of all, in a situation where there's metastatic disease that may be resected, even if it's completely resected, removed, the probability of recurrence is very high. It's the nature of metastatic neuroendocrine, is the probability is high of recurrence. It could be a long interval or a relatively short interval. In this case, it sounds like now there's evidence of recurrence. So in that case, that may be a situation where going on long-acting hormone is indicated as typically as the first line. Other nuances about the biology of it, what was the histologic features of it, the origin, the Ki-67, and other factors that could play into it. Again, we're not counseling on an individual case, but in the case, let's say if it's a well-differentiated mid-gut neuroendocrine that was resected and now has evidence of recurrence, liver and peritoneal in this case, I think the first thing we would typically recommend is appropriate staging. And I do think the Gallium-68 PET scan in this case was warranted. It sounds like it was, she had gotten it. There's measurable disease now. This would be an indication likely for long-acting hormone therapy, even if non-functional. The other question that comes up about what about surgical therapy of the recurrent metastasis? And that's sometimes, there's always a little controversy with that. We often don't necessarily rush right into it. Let's just see a little and see how things play out if it's non-functional. But there may be an option here if it's limited sites of metastatic disease, peritoneal even, and or liver, that's amenable to surgery, that potentially is an option. Again, it's hard without looking at the imaging or to provide specific counseling in this, but there may be an option for reoperation and resection of the metastases. So that may be something she may want to consider.
Got it. Thank you for that thorough answer, Tina. I hope that helped. And listen, this goes to you, Tina, and anyone else. If you're still in attendance and we get those questions and you have follow-up questions, you can send another question, obviously, to that. Or if it sparked another question in your mind, please feel free to chime in with any of the points that Dr. Choti mentioned. Folks, if you just joined us or joined us late, this is Luncheon with the Experts. We are back weekly again after a few weeks off for the summer. And today our guest is Dr. Michael Choti from Banner MD Anderson Cancer Center in Gilbert, Arizona. Is that right?
That's where the one site is located.
That's the one site.
Phoenix region.
Phoenix, copy that. And we were talking earlier about how Arizona does not subscribe to the daylight savings. I don't know what you would call it, format, I guess, that the rest of the states do. And I think Dr. Choti and I agree that that's a great way to be. I don't think anybody likes that anymore. So proud of Arizona for that. If you have any questions, go ahead and send them in. We are over 100 people in attendance today and climbing, which I love to see. And another thing I love about this show typically when you do videos, especially on Facebook, you start with the higher number and it just starts to decrease. And our show always goes the other way, where we start low and it just climbs and climbs and climbs for an hour, which is a great sign. It means that we're doing a good job. Let's keep doing that good job and moving along with the questions. Dawn says, I got a surgery question here. Dawn says, after debulking surgery and declared NED, which we just mentioned is no evidence of disease, by your oncologist, but you've never seen a NET specialist, should that person still consult with a NET specialist? NED after debulking surgery and declared NED by an oncologist.
I mean, the concept of a NET specialist versus a medical oncologist that has expertise in the area is a little bit controversial and a little bit difficult to say. I do think that it would be reasonable to have something like this, NED, but with a high risk of stage 4, with a high risk of recurrence. That someone with expertise needs to be following this patient. No, it doesn't sound like any therapy is indicated at this point. So some kind of surveillance is warranted. And so someone who has expertise knows what the frequency of surveillance, the technique of surveillance, and so forth, understands what management options there may be if a recurrence occurs. So I do think someone with some knowledge or understanding of how to manage this malignancy is useful. Now, NET expert versus not expert, it depends on the individual. There are very good medical oncologists and very good surgeons and surgical oncologists that are comfortable and have experience with neuroendocrine malignancies, and I think that would be very reasonable. If and when she develops a recurrence, then where to go from there. Sometimes, depending on the expertise of how or where it recurs, may be a reason to seek additional opinion, perhaps with someone with different expertise, may be warranted in selected cases. So, short answer is I don't think everybody has to. I don't again what this NET expert concept is, but someone who can comfortably manage the disease. And we mentioned earlier, this is one form of malignancy that sometimes not every medical oncologist, surgical oncologist is necessarily comfortable managing. Saying that, there's maybe some medical oncologists that are comfortable managing lung cancer or breast cancer or prostate cancer similarly, but this is one of those malignancies where sometimes medical oncologists may encourage individuals to seek someone with more expertise in any.
So if no evidence of disease after debulking, do you think just monitor?
Yeah, again, without knowing the specifics, no evidence of disease. Is that by imaging? Was there residual? Because debulking, that term is the role of cytoreductive surgery, that is removing all visible, measurable visible disease versus leaving low volume disease behind. And there may be situations in which there may be low volume disease left behind, let's say at the time of surgery, that was visible, but with imaging, one doesn't see it. So in that case, there may be some selected situations where therapy may be done. But the short answer is, if there's no evidence of disease after resection, removal of all evident metastatic disease, usually no therapy is given. In some cases where there may be some residual disease or minimal residual disease or whatnot, then the question of whether to go on the long-acting hormone therapy, that may be a little bit of controversy in that area. But if complete removal is done, at least in my practice, we typically don't routine, except perhaps in selected situations, recommend some kind of adjuvant hormone therapy.
Got it. Thank you, Dr. Choti, and thank you, Dawn, for your question. I hope that helped. Let's move on. Eleanor says, I had a low-grade carcinoid tumor removed from my lung. So another lung question. And this is a generic question. What are the chances of me getting a carcinoid tumor again after having it removed?
Yeah, it's difficult to say. That's a little bit without knowing the specifics. So two questions. One is, the implication there is getting another lung carcinoid. The suggestion is that a second primary is the question versus a recurrence of the new one. So just for the audience to understand that there's a significant distinction, and there may be some situations in which having a second primary, meaning a second new malignancy may appear. That can happen in the intestinal tract, or I imagine, and again, that can happen as a second in the lung. It's different than what was the probability of recurrence, and a small, well-differentiated lung neuroendocrine tumor and completely removed has a high cure rate. That is, has a low risk of recurrence. But again, there may be some specific features that could change that. So again, I would recommend a discussion with your primary expert to understand the specifics of the pathology, the margins, the other things related to that, is to understand her exact risk of recurrence. And the hereditary aspect too, there may be with regard to whether there's a higher or lower probability of a second neuroendocrine to develop.
Got it. Thanks, Eleanor. Joy says, are there any other non-invasive therapies to use other than the blanket or other than a blanket that octreotide works for everyone at a particular stage? Is this the only medicine found to slow the growth of these tumors?
No, there are not. I mean, typically that hormone therapy, long-acting, is often for well-differentiated functional or non-functional. That may often is the first line of therapy. That is what we first may offer. And then, depending if there's evidence of progression, then there may be a variety of different options, depending again on what's the tumor origin, the degree of differentiation, the Ki-67, the extent of the disease. And there are a variety of options from even surgical therapy. She asked about non-invasive, so there are certainly there are other systemic therapies, drug therapies, chemotherapy in some cases, or other forms of targeted therapies. There's PR, hormone therapy. So there are a variety of different options that maybe could be offered down the road in patients besides just the hormone therapy.
Got it. Thanks, Joy. I hope that helps. Seemed a few other people had that question as well. Let's see. Karen says, I'm new to the group and I had it in my appendix. I had it in my appendix. No treatment, no follow-up. Am I at any risk of relapse?
That's a good question. It often comes up. So appendiceal neuroendocrine, appendiceal carcinoid is actually not that uncommon. They tend to be somewhat more indolent. That is the lower risk of recurrence than originating in other intestinal locations, which is the small bowel. And often removal, even just with appendectomy, is the treatment of choice, and sometimes found incidentally with an appendectomy. A small NET is found in the tip of the appendix or whatnot, and that often is sufficient. Again, it depends a little bit on some features, the size, the differentiation, the margin, and sometimes we may recommend further surgery initially after, let's say, a simple appendectomy is done, identifying a small or identifying a carcinoid tumor in the appendix. Sometimes further surgery is recommended to remove the little bit more of the bowel around the intestine, the colon near the appendix, particularly because of to sample or to assess the surrounding lymph nodes in that area. It's unlikely that appendiceal neuroendocrine goes to the lymph nodes unless the size is larger. So the management of appendiceal often is appendectomy alone, small tumor, low risk. That's all the treatment. No really much follow-up at all is needed. No therapy is needed, and it has an extremely high probability that it will not recur. Again, bigger size, then sometimes we recommend further surgery mainly to assess whether the lymph nodes in the region are involved. If the lymph nodes are positive with an appendiceal, even if it's completely removed, again, typically no additional therapy is recommended, but we watch those patients a little more carefully because the probability of recurrence is higher.
Got it.
Hope that helps.
Nelia says, why do you still need the shots after you've had surgery? And let's talk about what shots we.
I think the shots are the long-acting octreotide that we've been talking about.
Right.
As I mentioned, if once someone has had surgery, if there's no remaining evidence of, certainly if there's non-metastatic neuroendocrine cancer, we mentioned the bowel, the pancreas, the appendix, the lung, and the surgery was done just on the primary tumor and there was no evidence of metastatic disease, definitely there's no indication for any additional therapy, including the shots. In the case of surgery where there was metastatic disease, we right, I think, spoken about it a little bit, even in that situation, at least in my practice, even if all the cancer, visible cancer is removed, then shots, we don't give adjuvant injections in that case. At least I typically don't do that. So the short answer is we don't give the shots typically after complete surgical removal. If there's visible remaining cancer, there may be some situations where, for example, surgery is done on the primary tumor for symptoms or whatnot, but there's evidence of residual measurable metastatic disease after surgery. Why yes, then the hormone injections are typically recommended as in those cases.
Got it. Thank you so much. Hope that helps. Okay, Amanda says, do you have any information or thoughts on the NET test? You familiar with the NET test?
Yeah, remind me a little bit about which NET test that is, or what the terminology is.
It's just called the NET test. It was developed by Irvin Modlin, who's been on the show.
I'm
Blood
actually
test.
not familiar with it. A blood
Okay,
test.
cool. Yeah, it's like it's been a while since I've had him on, but I think you can send in samples and then get results from the test pretty quickly. It's another controversial topic that comes up frequently.
We don't typically in our practice we don't use that test.
Got it. Amanda, I already see that our team on the back end has sent you a link to that, and Ren Laboratories, who created the NET test. We did have the very first episode of Luncheon with the Experts back in July of last year. We had Dr. Irvin Modlin, who created the NET test, on. This is something that a lot of people are discussing. Controversy might be too strong of a word, but there's a lot of debate about it right now. So I would look into the link that we sent you, find out more information about it. But yeah, I just know there's a lot of discussion going on about it right now. Next question from Anna. Can some of the language is a little off. The lanreotide injection damage the liver with long-term use? Can the lanreotide injection damage the liver with long-term use?
Yeah, it's a good question. I don't think so. I mean, I don't know of specific either anecdotal cases or data myself that long-term use of long-acting octreotide of some form has a damage to the liver that I'm aware of. So I don't know. There may be some specific cases, but I'm not familiar with that.
Got it. Oh, this is a statement from Fred. Fred says, I had my first PRT treatment yesterday. Good luck, Fred, and thought today would be boring, but you all changed that and came back just at the right time. So now I have something interesting to watch with your return. Fred, I appreciate it, man. That makes us feel good, and that's why we're here. Diana says or asks, why do some not show Gallium-68 scan yet on F-dotatate? Getting a little
Why some don't show up on that scan? Is that what you mean?
Yeah, I think that would be yes.
So that's a good question. Not all neuroendocrine tumors light up on gallium-68 dotatate PET. That is a extremely first of all, I think it's a huge advance, expensive test, and it needs to be used selectively.
Mm-hmm.
However, it's both for diagnosis and staging. It has helped a lot in our management. One feature is that typically not every NET takes the tumors are taken up by it, but typically those that are more well differentiated. So the ones that are less well differentiated, faster growing, and don't take up sandostatin analog are the ones that don't light up on this, and so
Okay.
those are often and so not only that those tend to be more less well differentiated, more rapidly growing, typically higher Ki-67 in some cases, which is another marker of more rapid proliferation, and potentially less efficacy of hormone therapy, or certainly a PRRT, which is a similar, which is radioactive therapy for it. So those are, so that's that, yeah. So every NET does not take up unless it's well differentiated, and but so it not only can help stage or evaluate the extent in selected NETs that happen to light up on this scan, but also can help us understand a little bit more about the biology, if you will, of it by its aggressiveness and therapy, because certain therapies are more effective in when the NET lights up on the gallium PET scan. So.
Got it. Interesting question. Not really about surgery, but see how you feel about it. Patty says, tumors in what area of the body tend to release the most histamine, causing an itchy rash? Any thoughts?
Yes, I don't know. I don't know. There aren't many that I know of, any neuroendocrine that cause necessarily an itchy rash. She may be, yeah. So rather, I don't know if it's specifically related to carcinoid syndrome she's asking about, or other
Possibly.
functional, as opposed to specific histamine release that's related to a rash. Not as common. I'm not necessarily familiar whether there's a specific hormonal pattern, except that it may be associated with with the standard kind of carcinoid syndrome that a midgut carcinoid, for example, can produce. There may
Right.
even be some functional pancreatic neuroendocrine tumors that are glucagonoma, for example, are associated with rashes and so forth. Whether that's related to what the mechanism of that is, it may be in part related to that. So I'm not sure exactly what she's asking. I don't know if she can clarify it or not.
Yeah, Patty, let us know if you have any other information. Hope that has a little bit of guidance. Next question from Cassie. Does carcinoid crisis during surgery have to deal more with the anesthesia or the manipulation of the tumors?
Yes, this is another area, a little bit of controversy. So carcinoid crisis, for those that in the audience aren't familiar, so this is a situation that's been described for decades in which patients who have carcinoid tumor and are operated upon can have hypotension and low blood pressure and hemodynamic instability, and even potentially life-threatening. And so there's a lot of kind of counseling advice about that one needs to be very cautious about that when operating on patients with carcinoid, with an NET, and in order to avoid this carcinoid crisis. It's an area we actually just a group of us just reviewed this particular thing, and we have a paper and a manuscript in preparation regarding this. It's very controversial, actually, whether it truly exists, how common it is, what exactly is going on with this. We are, tend to be cautious about it and make sure that patients are on octreotide therapy for those at least functional mid-gut neuroendocrine tumors, that in patients who have carcinoid syndrome preoperatively, those are the ones more likely associated with some kind of carcinoid crisis. So personally, I think it's a little bit overblown, the concept of it, and that many patients already who have carcinoid syndrome are already on long-acting hormone therapy that then mitigates the probability of any carcinoid crisis. And those patients in whom their tumors are non-functional, it's probably, a small, I don't know what, small appendiceal, whatever, it's pretty unlikely to then have a carcinoid crisis. So It's a little bit hard to define. I think the entity is real, but it's whether it's, and probably it's related to anesthesia and other factors, extent of surgery. I do
Yeah.
think it's real, related in some situations. I think out of precaution in patients certainly who have uncontrolled carcinoid syndrome, that it's reasonable to have short-acting octreotide either available or even hanging during surgery. I know many of my patients are like, oh my God, if you go to a surgeon and operates and is not, doing that, then they know nothing about NET. There's some truth to that, but on the other hand, I think there's an option to use empiric octreotide selectively when operating on NET patients. But certainly it's reasonable to have your surgeon at least understand the concept, be aware of the concept, use either routinely or selectively use short-acting octreotide in certain situations when operating on NET. And certainly if there are any situations that occur, it's certainly reasonable to also have the surgeon inform or that the anesthesiologist is aware that a patient who they're operating upon has neuroendocrine cancer. So those are all general guidelines, but it's area a little bit of controversy, but patients often come in very armed with a lot of information and are very afraid anytime they undergo surgery of a carcinoid crisis.
Yeah.
It's probably a little bit overrated as far as the probability of this occurring or the risk of it occurring, candidly. Saying that, I do use empiric short-acting octreotide on many of my patients who I operate on with advanced NET.
Got it. Thanks for your question, Cassie. Next question from Rhonda. And folks, we have just under 20 minutes left. We're moving right along. Great questions today. Appreciate you being here and asking those great questions. So Rhonda says, a nurse mentioned to me today about radiofrequency ablation, RFA. Could this be an option for small intestine nets that have metastasized to the liver?
Yeah, its short answer is yes, it could be an option. So ablation, whether is basically a technique, instead of surgical removal, whether it's in the liver or other sites, of using a probe placed in the tumor, either non-operatively or during surgery, and zapping it, basically destroying it. And the more common is some form of heat, either RFA, called radiofrequency ablation, or microwave ablation, what we typically use. Similar, it's just a probe that's placed and it burns the tumor. And it is an effective therapy. It's like, instead of cutting it out, you kind of burn it. And if it's completely burned, then it's basically as if it's completely destroyed. It is useful in particular in neuroendocrine, in some cases, metastases, because it's not uncommon to have multiple. And so if a patient has many lesions in the liver in which we're trying to remove, if you will, or all of them, and save sufficient functional liver, it's a therapy that often is used intraoperatively. So, removing some of the metastases and ablating some of them in order to destroy or remove, if you will, all of the metastases. So yes, it's a tool that I use certainly intraoperatively. It can be used percutaneously. It's effective. There's some nuances about it. If you have a large tumor, it's to partially burn and whatnot. When the goal is to really destroy the whole thing. So it's more useful in smaller, under 3 centimeter, under 2 centimeter. Also, the location of the metastasis, if it's near a main vital structure, you don't want to be burning that and then causing liver damage. So there are some limitations with regard to location and size and number, but yes, it's an effective tool in selected cases in order to achieve either complete removal / destruction of all visible disease, or even in the cytoreductive, where one is trying to, again, I mentioned that we try to avoid the use of the term debulk, but basically cytoreductive, where almost all, if you will, of the disease is destroyed or eliminated.
Got it. So our next question is from a first timer, Bonita. Bonita, thank you for joining. So she says, "This is my first time joining, so I'm sure this is already well known in the community." First of all, Bonita, I appreciate you asking the question, but even those questions that we discuss a lot, it's important for us to keep asking them, keep talking about them. So I'm glad you asked. And she says, "Is there a genetic test for neuroendocrine cancer? My mom is fighting a battle with it at the moment." So first of all, sending love and strength to your mom. And this is a question that comes up a lot, that is being discussed. Dr. Choti, is there a genetic test for neuroendocrine?
So genetic tests so they're different. That's kind of a broad terminology. So there's
Yeah, let's
one
break it
genetic
down.
test, so-called germline, where to look at hereditary forms. So is the question, is it a hereditary cancer,
Basically,
and so-called the germline genetic testing. It can be. It's not as common as some other malignancies. That is, there's many of the neuroendocrine tumors are so-called sporadic. That is, there isn't a strong family history of them. There are selected situations of multiple endocrine neoplasias and other things where they are where there's a true hereditary pattern and or mutations that can be identified in the germline. That means in the whole body testing for blood, for example, in order to see whether either that individual who has malignancy, uh, it's a hereditary version of it. Why that's important is in part to help counsel family members and so forth. The other term for genetic testing is more for uh, testing the tumor. That is, do test, and I don't understand specifically your question, but but is there a role for molecularly testing the genetics, the mutational pattern of the tumor, so-called uh, uh, somatic analysis or analysis of the actual tumor itself? So, and there are some potential mutational, what's becoming very common now on the molecular or the genetic analysis or the molecular analysis is to do uh, whole genomic sequencing or genetic sequencing of the tumor, even in so-called sporadic, that is non-hereditary patients, to try to determine a molecular signature to see if there are specific mutations within the tumor that may allow either predict certain therapies, for example, or prognosis. So there are in lung cancer and in breast cancer and in colon cancer, they're very important to do genetic testing of the tumor itself, somatic testing of the tumor, in order to determine if there's a molecular signature that then can help guide therapy or predict prognosis. In neuroendocrine tumors, there are potentially some, there aren't as, it's not as well developed that is, there aren't necessarily unique signatures. For example, immunotherapy is an area everyone asks about.
sure.
And there are certain molecular signatures in other forms of solid cancer, such as colon cancer and others that may then, that are uncommon, but still could provide information that this tumor may be sensitive to immunotherapy. In neuroendocrine tumors that are not as common, there's not as much of defined actionable mutations. This is the terminology we use that can be determined. So it's not as useful to do kind of whole genomic sequencing of neuroendocrine tumors. Ki-67 is a, if you will, it's kind of a form, not a so-called genetic testing, but it's a specific test that certainly, as I mentioned, can guide therapy. The other piece, just to mention on the genetic piece that may be of interest to the audience, not so much on the neuroendocrine, but on cancer therapy as a whole, is the whole concept of a blood test to study the genetic mutations.
Mhm.
It was so-called ctDNA, circulating tumor DNA, or some liquid biopsy. This whole concept is really something in cancer therapy that's really, I feel, is really emerging as really a game changer in how cancer therapy is diagnosed, monitored, and so forth. So one can see shed DNA in the bloodstream from the tumor that can be used not only to determine the full molecular sequencing of it without having to do a biopsy, but also we can use it in other ways. Sometimes even, again, it's being studied now to see if we can diagnose early stage cancer.
Mm-hmm.
For example, with first sign instead of on a scan or on a, is to see where there's already a signal of cancer DNA in the bloodstream. And then the other way, from a surgeon standpoint, we talked about cytoreduction or did you remove all the cancer? We're using this in not, again, I'll finalize with the fact that this is not common, unfortunately, yet in neuroendocrine, but hopefully it will be developed. But in other forms of cancer where we remove the metastases or not, and we want to know, there's no visible sign of cancer left in the body, but we want to know whether there may be minimal residual disease. So we can, after all the cancer is removed, if there's still residual cancer DNA in the blood, it's like, that means there's still somewhere in the body, still minimal microscopic cancer. And if there's not, then that's a better sign that there may not be. So this is an area very hot now in cancer: monitoring, detection, diagnosis, screening, therapies, everything. So-called ctDNA, liquid biopsies.
I like that.
But then to kind of follow with that, in NET, it's one of those malignancies, at least as of yet, there's not a large amount of shed DNA in the bloodstream. So unlike other forms of cancer where they tend to put DNA in the bloodstream a lot and more, even with low volume of cancer, in NET, we don't have yet the technology to really, that this is not ready, by far ready for prime time. But I'm hoping that research in the future, maybe more sensitive tests or other ways we can use this very exciting new tool in cancer management that's emerging over the next years to decades. Hopefully in the future for our NET patients, we'll see this come to fore.
Got it. ctDNA. Is that circulating tumor DNA? Is that right?
That's right.
Got it. Yeah, great. Thanks for that. And thanks, Benita, for your question. Hopefully that helped, and I'm glad you joined us. Listen, highly recommend you joining us every week or as often as you can. The benefit from this show is profound, I would say. And as I said earlier in the show, really the community that we've helped cultivate here is just as important, I think, as the information, quite honestly. So come on back, ask your questions. I'm pretty confident that we'll help you on your path moving forward. Folks, we got just less than 10 minutes left with Dr. Choti for today's show. We're going to keep plugging along. We've had a lot of questions today. So one more time, I want to reiterate, follow up with CCF if you didn't get your question answered. If you have a follow-up question, you can message them here or reach them at carcinoid.org. Starting Monday, we'll republish this to YouTube for those that don't have Facebook. And after the show is done, it will live here on Facebook on the videos tab. You can always refer back to it. Speaking of Bonita being, new to this and new to the show, I know we've have very educated people in this community, but I also like to treat everybody as being kind of new to this disease, and some people are when they attend, and help them understand that kind of foundational knowledge. And so Tina has a question that, we've referred to this or alluded to this a couple of times today. Very simple, question, but it is important for this disease. What is the difference of functional and non-functional?
That's a good question. So, and it can be a spectrum. So neuroendocrine tumors can sometimes elicit or secrete, if you will, hormones or other molecules that can cause a symptom. So, and that's what we call a functional. So just because one can measure something in the bloodstream, that doesn't mean it's functional. It really needs to be something that the tumor is liberating a hormone or liberating a chemical such that it's resulting in some clinical syndrome or symptom. Typically, and it depends, it used to be in the old literature, 80% of neuroendocrine tumors were functional. It's probably the other way around now, in part because we understand the disease more. More of these are being diagnosed incidentally and so forth. So certainly this applies to the pancreatic neuroendocrine, where now it's uncommon to find a functional pancreatic neuroendocrine, where in the past, most of them were, at least historically, were reported as functional. So it's a hormonal syndrome, basically based on a chemical or hormone that the tumor is secreting and causing a symptom. Again, so non-functional means you've got NET, metastasis or not, in which metastatic or not, in which, except for the local symptoms it can have. And again, this is not from a local symptom of pain or blockage or whatever. It's related to the liberation of in the bloodstream, if you will, of some active that's causing a symptom. Among the functional, the more common is the if it's in the midgut neuroendocrine, so-called carcinoid tumors of the midgut, ileum, and so forth. Sometimes other sites. The more common functional tumor is the classic carcinoid syndrome that we talked about: flushing, diarrhea, those kinds of symptoms. That's the more common. One needs to be careful about, by the way, about midgut neuroendocrine tumors, because sometimes diarrhea can be associated not necessarily to the functional for the hormone, but just to the tumor itself, causing partial blockage that can change the bowel habits that can manifest as diarrhea, but it's related to the mechanical bowel impact on the bowel of a non-functional tumor. So that's, if you will, but if it's liberating a hormone associated with serotonin and so forth, that can result in this carcinoid syndrome. And in the pancreatic neuroendocrine, very distinct group of functional. So these are neuroendocrine tumors of the pancreas, which are typically related to the islet cells, if you will, within the pancreas. So the functional tumors within the pancreas are typically insulinoma, tumor making insulin, glucagonoma, a tumor making glucagon that results in diabetes. Insulinoma results in low blood sugar. Somatostatin that can cause diarrheal syndromes, VIPoma, these other uncommon functional tumors of pancreatic, of PNET, of pancreatic neuroendocrine tumors. So there's a whole host of gastrinoma is another one. So where it produces the hormone gastrin that can result in a variety of symptom complex. So those are the kind of class of functional. It depends on the primary site as to what functional types there may be. And by the way, the triatide we mentioned, the hormone injections are often effective at controlling, not only controlling the growth, as we mentioned, of even non-functional metastatic tumors, but also can control the hormonal symptoms of functional tumors. So that those are and can even be useful to differentiate if you're not sure whether a symptom is from a hormonally functioning tumor or some mechanical. You see that it improves on triatide injections, for example, then it's indicative that it's probably a functional tumor.
Got it.
I hope that answers that question. Good question.
Yeah, definitely, and is one that needs to be answered before we can answer a lot of other ones. So we just have a few minutes. I have one more question for you before we go, just to kind of tie it back into where we started when we were talking about how long you've been working in this, and the stride. The first question I asked you was the strides we had made over 3 decades with this. And you mentioned that, and we're still learning, we're still trying to get better, we're still trying to understand more about this disease. What would you like to see? Like, what are the areas where you feel like we could really make progress if we could just unlock this thing? Does that make sense? Like, are there certain areas of this disease, like, man, if we could really solve that, it would, open up opportunity?
I think we need to continue with the advocacy groups and others to continue to fund research in neuroendocrine, so we continue in this area, clinical trials in this area in the last minute, because we mentioned a little bit about oncologists and everything, not understanding the disease and sometimes failing to diagnose or failing to manage. Sometimes there's a spectrum on the other side where there's a lot of individuals or providers that are promoting either different therapies or aggressive on both extremes. So I think there are both extremes of management here that are that I think we need to kind of standardize a little bit, because there are reports about certain therapies that maybe that may have yet to be fully proven and are being espoused by some. Others are not. So there's a wide spectrum of understanding of the management that often results in either failure to provide appropriate therapy, or sometimes even to aggressive therapies that may worsen prognosis in patients who may have very indolent disease. So we need to get that balance better, with better understanding, better standardization, guidelines, and so forth, so that, because it's resulted not only in a wide variance in how patients are treated, but also in confusion among patients and caregivers and others about what's the best approach. So just like we have to be, and sometimes there can be things that kind of go viral and recommendations that sometimes patients want to seek therapies in which there may not necessarily always be appropriate. So that's, I think, important, how we get that kind of standardized. And I think foundations like CCF are very helpful in doing that.
Thanks for that. Appreciate that. John says, glad you're back on. Didn't realize until 20 minutes left you have really been missed. Thanks, John. We appreciate you tuning in. And I just wanted to make a point to you and anyone else, and we added this into the comments as well. You can subscribe to the CCF newsletter, and they'll tell you, the upcoming shows, the upcoming guests. So if you want to, stay in the loop, so to speak, and know what's coming up for Luncheon with the Experts, that's a good way to do it. Folks, that is our show for today. Dr. Choti, thank you so much. I appreciate all the thoughtfulness and the thoroughness of your answers. And I know that people do too, but I appreciate your time today.
My pleasure. Thank you very much.
Absolutely. And thanks to you all at home. As always, we hope this program helped answer some of your questions. Again, reach out to ccf@carcinoid.org or here on the Facebook page for further information, or if you have other questions. As always, thanks again to our presenting sponsor, Tercera Therapeutics. Could not do this show without them. And finally, my name is Rain Bennett. Thank you for watching today. I've been your host. Please join us next week on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.